Maverick Physical Therapy, welcome to our first case study amongst this series on differential diagnosis. So there's several other previous episodes that have kind of set the stage to lead us into where we're at right now, and to re-highlight, I'd like to take a little bit of very brief time before we get to this very unique case and story, and highlight and to give a shout out in terms of what we're trying to do. And ultimately, we're trying to promote and encourage you as the patient to being able to have the best access to healthcare professionals and practitioners in regards to treating you, to have the best eyes and minds possible on you, and for things to not to go uncovered, to go unnoticed, and for you to get better. So we want to, throughout these series, use these as an opportunity to be able to educate you to the max so that you're well prepared in regards to what potential questions you could be asked and what you as the patient actually do provide in terms of giving us information as the practitioner that we need to be building upon so that we can hypothesize and then go through our testing and give you an end result in terms of what that impairment is, and then where the root and what the root of the problem is. So with that said, our medical field is in pretty rough shape today. We're oftentimes categorized based on a diagnosis, based on an anatomical location. We oftentimes only have a few minutes, maybe 5 or 10 at most, when we go in and see a medical doctor and kind of go through our problems. And a lot of times their head is stuck in some form of technological device documenting and writing stuff down, which for the purpose of documentation, totally fine. But we can't lose sight in the fact that we need to facilitate good conversation with these patients, because ultimately they give us the answer, and we could be missing some very big things in attempting to treat individuals that are not within our scope of practice. So I want to promote physical therapists today. I want to promote the applied functional scientist that is a physical therapist today, that is by far the best diagnostician in the orthopedic field of healthcare. One that will be able to tell you what you have going on and where the root of the problem is, and if you're not within their scope of practice, and providing you with some great care to be able to resort to. I'm holding a snowmobile because this story takes place in the winter months, March of 2015. My dad and I and my grandfather, it's always a thing, a tradition growing up, we'd go into the Upper Peninsula of Michigan, being from Michigan, and my dad and I and a few of our really great friends spend a great deal of time up in Ontario, Canada, where the best snow is, the best temperatures are, the best trails, play areas. And this story involves my father. And in the middle of March of 2015, when I headed home, we got back early morning, about 1 a.m., and we got up bright and early, 5 hours after that, 6 hours after that, and headed on out. And didn't have a whole lot of time to watch my dad move around or anything like that, notice anything different. Took our truck ride on up, 8 to 10 hours on up north, up through northern Michigan, upper and lower and upper peninsula into Ontario, to where we always start in Wawa, Ontario. And it wasn't until after we got to our cabins, our cottages, and we're unloading our equipment. After we unloaded our equipment, had to walk through an icy, snowy parking lot, up a few flights of stairs, or a couple flights of stairs, which probably consisted of a good 40 steps or so, and into the main hotel and into the restaurant. And as soon as we began doing that, I noticed with regards to my dad, walking like he had just gotten off a horse. So taking short steps with a really wide base of support, and looked really painful. And I'm watching him, and we get up to the hotel, eat our dinner, and come on back. And man, I noticed on the way back he is struggling. And it wasn't until when we were walking to originally, where's my dad at? So he's way back. I'm like, what the heck? So on the way back, I'm like, hey, what's going on? What do you have going on with your your body? What are you in pain or what the heck happened? So yeah, it's been going on for like 5 or 6 weeks. I'm like, what are you talking? Haven't you mentioned this to anybody? Never gave me a call. Have you gotten checked out? No, which is pretty typical. High threshold of pain. I'm like, well, what happened? Have you had an injury? What's going on? It's like, well, my groin is really hurting on both sides, and 5 or 6 weeks ago, we had some ice storms back home down in the Lower Peninsula, and with my dad being a fruit and vegetable grower, he was shoveling and scraping off the loading docks at his storage so that he could load boxes of apples on semi that came on into the loading dock. And after the ice storm, it was wicked slippery, so he fell on 3 different occasions, one hitting the back of his head, one landing on his tailbone, and the other landing on his right ilium, so basically the right kind of hip bone. And in my own mind, by watching him walk, I'm already hypothesizing what he has going on, but I'm like, no. But I wanted to find out, like, hey, how was there an injury? What makes it worse? Well, weight bearing. Anytime just getting up and on my feet and walking around, it just keeps getting worse. Does anything make it better? Well, when I rest, don't do anything. Injury-wise, was there a mechanism of injury? Well, the fall has started, shortly thereafter, and for the last 5 or 6 weeks, right after it happened, it's been super flared up. And so, as a clinician, we're going to get a little bit nerdy with this talk, but for your sake, and for everybody's sake, we kind of have to. So, as a clinician, I'm watching him move biomechanically, feet and ankles and hips. The only thing that he has going on previous medical history, he's never taken a medication in his life. He has no ACLs in both knees. So back in the day when he was younger and playing some volleyball, ACLs blew out, and those are in the days where they didn't perform reconstructive surgery. When there was a complete blowout, casted you up or braced you up for several weeks and have at it. Go have some fun. Well, over time, knee-wise, some significant genovarum, so some significant bow-leggedness, and with that, to provide stability throughout his body, we call it a dormant butt syndrome, not much of a butt because, hey, we don't have stability to be able to support the system, so I'm going to invert the heels. I'm going to lock out that mid-tarsal joint with relative adduction to give me something stable to be able to move from not having a butt, not having the stability of the knee. And as we lock out that subtalar joint into inversion, so I'm over exaggerating, but the heel's rolled on out, mid-tarsal joint right here, let's say on the right foot, locked out into relative adduction and relative eversion to give us something stable to move from. So me and myself, first of all, okay, let's screen you. You're so flared up. I mean, you're almost to the point you can't even move. You're so flared up and so hot. And he's describing 9 out of 10 pain. I don't know if I can hop on a snowmobile and go snowmobiling with you all. And I'm like, holy crap. So, all right, let's rule out. Is this coming from the hips? Is it coming from the lumbar spine? So, flip them over prone. Can you get on your stomach? Yep. Let's go through the lumbar spine. Let's do some accessory mobility stuff. No reproductive symptoms key. We need to be able to reproduce symptoms with movement, and we need to be able to take them away with movement. We already know that going into transformational zone 1A at the hip, flexion, adduction, internal rotation of the hip occur. He hates that. That's a big clue. Wasn't coming from the lumbar spine with all this accessory mobility. I'd much rather do this stuff standing up, but with the hips, with the groin, I should say, being as flared up as what they are, and what they were, I wanted to go through some other tests first. My dad, I'm gonna really stir some things up, flared up, but we need to be able to take this away with movement too. So it might be sore tonight and into tomorrow. Okay, lumbar spine, we rule that with our accessory mobility out. Okay, he's got some left C-curve scoliosis going, and basically in a standing position, a right ilium that's higher than kind of the left, and just some really tissue that's really on fire. Flipping them over and rolling them in the supine position, run a quadrant test, a Scholar's test, maximal and passive range of motion flexion, an adduction max flexion, internal rotation max flexion, adduction internal rotation. Flared him up through the roof, talking 9 out of 10 pain in terms of just irritation and just flaring on up. So what took it away though, so all positive tests, which I had hypothesized that they would be, I'll give you the tissue specific impairment here in a second, a lateral hip distraction took and alleviated away. Hey, it's down to a 4 or 5 out of 10. Took my belt off and his belt off, wrapped it around, and in a supine position, his hip down to the groin, and my hip, give him some more lateral hip distraction. Hey, that feels a lot better. Take him up into a doorway in a chair. Get him straight into TZ1A. TZ1A, right foot on up, dad, hands on the door. I'm gonna have you weight shift kind of just forward and backwards. Actually, before we went to the door, we started flat ground. I'm giving him a lateral hip distraction with 2 belts intertwined between each other to basically create space in this hip joint capsule, which is symptomatically taking things away, a quick responder. Very rare to have this going on. Degenerative joint disease of the hip. Before we got on up, I said, Dad, you've got, so basically what you have going on, you have degenerative joint disease of both hips. What does that mean? It means that you have so much friction placed in one small area, you've worn through the cartilage and are down to the subchondral layer of bone where there's nerve endings, hence your pain, meaning someone at some point in time will perform or would want to perform 2 total hip replacement surgeries on you. Look on his face, death, terrifying. So quick responder, we don't get this very often, maybe 1 out of maybe a few hundred or 500 patients in which, hey, we can go at them right away, create motion. We've got basically the hypothesis is from this fall, which is basically like a motor vehicle accident that stirs things up. We land on a portion of our body which exacerbates some symptoms that are pre-existing, and even though I started to have pain, it didn't just happen. It's been accumulating for years because of a lack of mobility and a lack of bigger stability. So we have a stability, we have mobility deficits. Goniometer wise, hip mobility, probably 5 to maybe 10 degrees of internal rotation with some of our tests. Adduction, maybe 5 or 10 degrees after we got that lateral hip distraction going. Significantly improved things. So with degeneration of the joint and the joint capsule, which almost becomes kind of like concrete, gets locked down, concretitis per se. So we went after opening up the hip joint capsules, flat ground first, and just kind of this the sagittal plane, just kind of rock forward and backwards. We got a little contralateral arm, upper extremity driver going so that we could load up into internal rotation further. As I was given a lateral hip distraction to take the femur away from the pelvis. So we gave him some things that he could do on his own, some stretches he could do on his own. Every morning then we went about this process of going through and cleaning up, doing some functional manual therapy, some functional manual reaction on the hip joint capsule, which took away his symptoms. And as we got home, set him up with some videos via my business to take care of in regards to a home exercise program to alleviate these symptoms, create space, and allow him to close the gap on what his genetic potential is.